Hello, and welcome to an Applied Radiology Expert Forum webinar. This evening, we will discuss leveraging artificial intelligence in a COVID-19 environment. This program is made possible through a collaborative effort between New York University School of Professional Studies, and in particular, Adjunct Assistant Professor Kenneth Wheeler, and the American Board of Artificial Intelligence in Medicine, who together have assembled an all-star team who will speak to you today about the growing role of AI in medical imaging and how we might leverage AI in the battle against COVID-19. So with that, let me introduce our esteemed panel, and I'll start with Dr. Anthony Chang, who is a pediatric cardiologist and medical director of the Heart Failure Program at the Children's Hospital of Orange County, otherwise is known as CHOC's Children's. He is the Chief Intelligence and Innovation Officer and founder and medical director of the Sharon Disney Lund Medical Intelligence and Innovation Institute, also at CHOC. He serves as the co-director for MI3 Summer Internship Program, and Dr. Chang is also the author of a new book, Intelligence-Based Medicine Principles and Applications of Data Science, Artificial Intelligence, and Human Cognition in Clinical Medicine and Healthcare. I should also mention that Dr. Chang is the chair of the American Board of Artificial Intelligence in Medicine, who are collaborating on today's event. Dr. Chang, welcome, and thank you for joining us. We have you on the line.
Thank you so much, Karen, for having me tonight. Thank you.
Super, super. Next on our esteemed list here is Dr. Bhatia, who is a pediatric radiologist subspecializing in pediatric neuroradiology with a current research focus on using advanced imaging for monitoring treatment efficacy in CNS tumors, including the use of artificial intelligence and radiogenomics. His publications include a review of pediatric CNS infections and diffusion tensor imaging of the pediatric spinal cord. Dr. Bhatia, do we have you on the line as well?
Yes. Hi. Thank you for having me.
Super. Thanks again for joining us. Up next is Dr. Patrick Jameson, a product manager for InterSystems. Early in his career, he practiced neurology at the University of Pittsburgh while doing informatics research in medical expert systems. He was the product manager for real-time decision support at Cerner Corporation. Dr. Jameson, thank you for joining us. Do we have you on the panel as well?
Yes, thanks, Karen. I'm glad to be here.
Lovely. Next on my list here is Dr. Sonia Gupta, a fellowship-trained abdominal imager who is the Director of Ultrasound Services at Beth Israel Deaconess Medical Center and an instructor of radiology at Harvard Medical School. Dr. Gupta subspecializes in obstetric ultrasound, abdominal ultrasound, MRI, and CT, as well as image-guided procedures. Dr. Gupta is optimistic of the positive changes artificial intelligence will bring into the realm of healthcare delivery services to patients, as well as its impact on improving radiologist expertise and accuracy. Dr. Gupta also consults for Google, IBM Watson Health, and AI marketing research. Dr. Gupta, thank you so much for joining us. Do we have you on the line today?
Yes, thank you so much. Very excited to be here tonight.
Oh, wonderful, wonderful. And finally, I have Mr. Charles Stanley, I should say, who is an experienced imaging professional with over 30 years experience in radiology, CT, MR, veterinary imaging, and imaging management. Mr. Stanley currently holds advanced certifications in MRI, CT, radiology administration, imaging informatics, and MRI safety. He is a senior medical liaison for Gobet, and in this role, he works with top academic researchers from around the U.S. and Europe, as well as providing scientific support to their end users. Mr. Stanley, thank you for joining us. Do we have you on the line?
Thank you, Karen, and I'm honored to be able to participate this evening. Thank you very much.
Super. Well, I appreciate all of you taking the time to join us tonight. I'm Kieran Anderson, Vice President and Group Publisher here at Applied Radiology. I will do my very best to act as your host and moderator tonight. In a moment, we'll begin with the first of 5 short presentations, each of which will be followed by a brief Q&A, and we do encourage you to submit questions as they come to mind anytime during the event. Following all 5 presentations, we'll have time for a final panel discussion where we'll do our best to get to as many questions as possible. So before we get started, let me just share a few quick programming tips for you. You should be seeing a screen that looks something like this. If you would like to enhance the slides and make them a little larger, you will click up in this area here. Over in the resource area, we've provided a few links as well as a PDF of a recent white paper that Dr. Chang has authored that may be of interest to you. To ask questions of our audience at any time during the event, please enter your question here and click Submit. And finally, at the bottom is our control panel, which does allow you to toggle these windows in and out of view to make more room on your screen. So that is pretty much it for the setup here. At this point, I'm going to go ahead and turn it over to Dr. Bhatia, who's going to begin with his talk. Dr. Bhatia, the floor is yours. I'll mute myself and the rest of us here, and please take us away.
All right, thank you. Appreciate it. So yes, I'm a radiologist that focuses on neuroradiology and chest radiology, so I do a little bit of both and have a great deal of interest in AI, and that's the area that we'll be focusing on today. So disclosures, I'm a consultant for Group A, and the presentation does not provide medical advice. So we'll discuss some of the initial background information on COVID-19. We'll go into some of the chest radiology, and then we'll focus on the AI component, and that'll be primarily on chest radiology. There's not enough neuroimaging findings currently, and it's really in the early stages of our understanding in the brain and spine. So we'll focus on that area at the end. So I've been presenting on this for the last few weeks, and every time I'm ready to present, the number of cases significantly increases. This is an example. 2 weeks ago, there was about 330,000+ cases in the United States. And then just a few days later, there was over 600,000. And just recently, over 800,000 cases in the United States. And throughout the world, there's been a tremendous number of cases. Some areas hit harder than others, such as Spain, Italy, the UK, and China. And this goes along with the number of deaths. The United States, a few weeks ago, had 10,000 deaths reported. Just recently, 30,000 deaths. Just a few days ago, 40,000 deaths. And then today, there was a report that in the United States, there's over 50,000 deaths. And so that significant increase in the number of cases has also goes along with the amount of information we're receiving every day. So there's new literature coming out every day. So it's really hard to stay on top of the information coming out, but it's very important during this pandemic. And a lot of information we know about this pandemic is related to other past coronaviruses. So MERS and SARS were past coronaviruses in 2012 and 2015. 2018 was MERS. SARS was about 2002 to 2004. And these were outbreaks. These weren't pandemics. There were less cases, so 2,000, 8,000 cases for MERS and SARS. Less deaths compared to SARS. This is a slightly older data, but the case fatality rate was much higher in MERS, so 37% fatality rate compared to SARS. COVID-19 is about 2 to 7% range. It's not clear right now with the number of asymptomatic patients out there, and a lot of data still being analyzed in different countries. But a lot of the studying and research that was done on MERS and SARS has provided us some information on COVID-19. A good example is that UPMC, we're in the early stages of a vaccine in COVID-19. A lot of that was done related to the work from studying vaccines on MERS and SARS back in 2012 and 2013. Just a brief overview of the structure of COVID-19. It's an RNA virus that has these little spiked glycoprotein S. You might hear about this a lot. This is the receptor. So basically, this is how the virus can attach to the receptor on the host cell. This could be animal cells or human cells. So the ACE2 is the receptor cell or the receptor on the host cell that allows entry of the virus into the host cell. It's important to know that the virus doesn't have the machinery to duplicate or replicate itself. It uses the host cell the host cell's machinery to duplicate itself, and that's its sole purpose. And in that process, it compromises the function of the host cell. And you can imagine if it took over a number of cells within the lung, it compromises the function of that lung, or in the kidneys, or in the brain, as other examples. And the genomic epidemiology of COVID-19 is very interesting. So on the x-axis is time. So December 2019, starting on the left, going toward the right, is the genetic variation or strains of this virus. So the purple represents the strain that was first reported in China. As you go along the timing of this virus, that the variability has changed. The genetic variability in this virus has changed with, let's say, purple represents one strain, red is a different version, yellow is a different version, green is another genetic strain. And as the genetic variability in this virus changes, it also provides challenges for us as researchers and scientists. So if you're developing a vaccine for, suppose, the purple strain, is that vaccine going to be relevant or effective against the red strain and vice versa? And this is a nice map showing how the spread of this strain from China, the purple strain, was first reported. It entered Europe, mutated into different versions of this virus. We'll call them just by the colors, the green or yellow strains. The virus within North America actually mutated into a red strain. So the concern is if this strain now comes back to China, the people that are immune to this, is the population immune in China, are they going to have the immunity to the red version of the virus or the red strain? And same goes for Europe. Are they immune to the red version or the red strain? So as the genetic variability increases, that's one of the concerns. And also the natural immunity to this virus. So whether it's vaccines or natural immunity, is this variability in the virus going to be effective amongst all these different strains? And as we're studying them, it's also important to know, are we comparing the same strains? Do we have to divide them into different subgroups or sub-strains to further understand them? And that's where AI can come in handy when we're analyzing a large amount of data. As you've seen, the number of cases is very large. It's pretty hard to analyze all of that data. So this is somewhere where computers can help us and AI can help us. This is just a video showing that as it spread from China as the purple strain, it's then infected areas such as in Europe, Australia, and then that mutated into a different version, the yellow-green version. In North America, it mutated into a red strain that then can come back and infect other areas. And that's just a little video of that. And so our understanding of past pandemics will be helpful as we prepare for possible second and third waves. So Dr. Fauci and other infectious disease doctors have suggested that this is possibly the first wave. The second wave can be even more deadly. And this is, if you look at box B, which is 1918 to 1919, that's the Spanish flu. And what we know about that is the first wave, so the percentages demonstrate the number of deaths during the pandemic. So with the first wave, there was about 5% of the deaths reported during that pandemic. With the second and third wave, that's where really the highest percentage of deaths were. So that's why they suggest that the second wave could be deadlier based on past pandemics. These are influenza pandemics, but also provide useful information for us to prepare. And this is another reason that the scientists and the medical community have united on this, is because as we try to get through the possible first wave only, we need to prepare ourselves for possible second and third waves of this virus. And so the quicker we can analyze data, the quicker we can understand imaging findings, the better we'll be prepared for possible future waves. And that's another reason AI can come in handy in this case. So I'll go over some of the chest radiology. As a radiologist, there's been a lot of questions. Can we use CT for screening? So a lot of societies have put out different consensus statements. And the Fleishman Society is an international society dedicated to thoracic imaging, probably the best consensus statement I've seen. And I'm not going to go into all the details, but if you're interested, this is a good reference. The main point I want to make is that, as most of the societies have suggested, that CT is not a good screening test for COVID-19. And that's because the imaging findings are non-specific. And also, if the CT test is negative, it doesn't necessarily mean that the patient doesn't have COVID-19. And so some of the first reported imaging findings were in this article in Radiology Journal, Sensitivity of Chest CT for COVID-19, so in February 2020. And these are classic findings. So there's typical findings and atypical findings of COVID-19. This will be more a typical finding, and I'll give some background information. This is a chest CT. It's an axial cut, so the black areas are the normal lung, and the orange circles are showing areas of this kind of bright or dense areas, and that represents infected areas of the lung of COVID-19. And this is what we would describe as ground glass opacity. So it's kind of bright, but you can still kind of see through it and see the underlying lung. So that's what we will call ground glass opacities. And that's a typical example. This is another patient with COVID-19. So the orange circle represents ground glass opacity. The blue or purple circle represents more of what we call a consolidation. It's more dense, much brighter. You can't see the underlying lung. And then the green circle represents ground glass opacities with interlobular septal thickening, so crazy paving. And the only reason I want to mention these other types of opacities, some of the AI softwares that are being developed and are already available can differentiate these different types of opacities within the lungs. Currently, the relevance of that is not known, but as we study more and more, since there's a significant number of cases, it might be useful to know if ground glass opacities or consolidations or crazy paving have any relevant info as far as what patients will be worse or better based on the type of opacity. So this is another patient with ground glass opacities in the peripheral part of the lungs, not as extensive as the other patients. And this is a patient with ground glass and consolidations in the right lung. So these are examples of COVID-19. And what we can do with the CT is we can reconstruct it into different planes. So that was an axial or transverse cut. This is what we call a coronal cut of the CT. And these arrows point to different areas infected in the lung. What's really useful here is you can do a 3D reconstruction. And this video will rotate, showing the purple part is really relatively normal lung, and the bright areas represent infected parts of the lung. So in a quick assessment, I can get a good idea of the infected areas of the lung with these 3D reconstructions from CT. And this was a nice study for one reason. It will show asymptomatic patients. So this was patients from the Diamond Princess, which was a cruise ship off of Japan. So a lot of these patients were infected with COVID-19. This is an example of an asymptomatic patient. So all those areas are pointing to infected portions of the lung. The black areas are normal portions of the lung. And in my clinical experience, I haven't seen viruses of asymptomatic patients. We usually don't image asymptomatic people anyways, but when we image patients for other reasons, we usually don't see opacities like this. If they're coming in for supposed metastatic disease workup, this is very unusual to see a virus like this in an asymptomatic patient. So this is a significant amount of lung involvement. All these areas of bright intensity or density represent infected lung or secondary to an infection of COVID-19. And this is, when we discuss asymptomatic spread of the virus, this is important to know that someone's lung can look like this and they can have no symptoms. So this gives you an idea of potential ways that an asymptomatic patient can spread the virus. And as a radiologist, what my training has put me in the situation to do is differentiate possible infections. So COVID-19 is a new virus. We're not familiar with it. We're learning as we go. The typical findings of peripheral ground glass opacities, I have a understanding that this is a different virus. This is RSV. So this is, in comparison to COVID-19, this type of abnormal lung is easy to differentiate for a radiologist. So you can see these pre and bud opacities where the orange circle is. So that's not typical of a COVID-19 infection. This is active tuberculosis, where you have these, let me go back. This is an example of active TB where you have these nodular opacities throughout the lung. So this is atypical for COVID-19, and this cavitation with the lung where the arrow is. That is not what I would suggest COVID-19 to be. Klebsiella pneumonia, another example where you have a cavitation where the arrow is. The orange circle is demonstrating opacities adjacent to the heart or mediastinum. This is also not typical of COVID-19. So as a radiologist, I feel pretty comfortable differentiating those from COVID-19. And this is a drug toxicity showing granular capacities where the orange circles are. And really, it's throughout the lungs. I just wanted to focus on a few areas that were obvious. And those are granular capacities that are now looking more similar to COVID-19. So it's becoming a little more difficult to differentiate PCP pneumonia, another granular capacities throughout the lung. So this is looking even more like COVID-19, even harder to differentiate. And now you have consolidations throughout the lungs in an influenza A pneumonia patient, so even harder to differentiate. This easily could be COVID-19, and the past two cases could also be COVID-19. And so as we transition to the talk of AI, it's important to look at how computers can help us. This was a study showing radiologist evaluation of lungs, and what they were trying to do is give an assessment of how much lung is aerated versus what is not aerated or infected by the COVID-19 pneumonia. And they compared it to a computer software that was able to quantify the area of infected lung versus aerated lung. And this is just an example of the software that it took the right lung and left lung and separated into upper, middle, and lower lung zones. It's then quantified what portions of the lung were infected. So the green represents aerated lung, and the yellow represents infected lung by COVID-19 pneumonia. And you can, in this case, this patient was admitted to the ICU. So almost half of the lung was infected in this patient. And what they showed was that this software was able to predict what patients would be admitted to the ICU and which patients were more likely to die from the infection. This is an example of where a good portion of the lung is actually aerated. So about 81% is aerated, and this patient was discharged home from the emergency department. So as an example, the software was actually better than the human in assessing the amount of aerated lung. And I can say on almost all of my CT reports of an infection, I never quantify how much lung is involved. I might be very subjective and say mild, moderate, or severe. But when you have software like this that can help quantify and look for statistical significance of what number, what proportion of lung aerated versus infected would help us decide on what patients have to be admitted, what patients might need intubation, what patients can be sent home. So now we'll talk about artificial intelligence in a few cases. So the Pittsburgh Center for Artificial Intelligence Innovation in Medical Imaging is led by a great group of people. We have Dr. Shandong Wu, Dr. Ashok Panagrahi, and other great members. So I'm very fortunate to be part of this group, and they have a great deal of interest in artificial intelligence in imaging. And so we're already in the early discussions of how we can use AI in COVID-19 evaluation. So a lot of people out there might not have the personnel or the hardware to produce AI software for COVID-19 currently, but here's an example of free software that's available currently that can help in the assessment of COVID-19 patients. It's from IntraSense software. It's a free software tool available. And once you download it, you can use this COVID-19 tool. There's different tools, but the COVID-19 one is available for free. And what it allows you to do is you upload your CT, and you can differentiate aerated lung in the right versus left lung. It can differentiate the airways. And this also uses algorithms to help differentiate the densities of the infected lung. This is one example of software that can help a radiologist decide on how much lung is infected and potentially relay more objective data to the clinician. And also for research purposes down the road, it's, in my opinion, much better to do objective assessment of infected lung versus subjective evaluation. And so when we talked about the consensus statements from different societies, it was pretty clear that chest CT should not be used for screening purposes. But this was a nice study showing how AI can distinguish COVID-19 from pneumonia, community-acquired pneumonia on chest CT. So they looked at multiple chest CTs. A convolutional neural network was used to evaluate these chest CTs, and the outputs were weighted as far as, is this patient likely to have COVID-19, community-acquired pneumonia, or non-pneumonia? And what this algorithm was able to differentiate or show was that there is specific findings maybe that we're not picking up early on, but COVID-19 had a very high sensitivity with this algorithm and specificity, as well as with community-acquired pneumonia and non-pneumonia cases. And they're all statistically significant with statistical analysis. So I think one negative would be there's not a lot of cases in this study. So as the algorithm is built up with more and more cases, it's possible that the algorithm could become better. So these numbers could actually be higher even. But even with the low number, it's hard to say for sure. It would have to be tested against another data set and obviously tested in the clinical environment. But with the whole AI concern, there's always that black box concern of what the algorithm is actually looking at. How is it determining COVID-19 from community-acquired pneumonia? Well, you can use these hot zones. So this hot zone depicts what areas the algorithm is focusing on. So here's the chest CT on the top row and the hot zone. So the red area focuses is showing you what the AI algorithm is really focusing on. So if you look at the chest CT, it is focusing on the correct areas. Those bright areas within the chest are infected lung. And so at each slice of the chest CT, the algorithm is accurately focusing on the area that you should focus on. And the black area is the normal lung. There's no hot zone or there's no color there suggesting that it's not focusing on that. So it's just a quick way for us to test that the algorithm is properly working. This is a community-acquired pneumonia case. The first column demonstrates normal lung. The second one shows some infected lung with the dense areas or the bright areas within the lung. And the hot zone properly is focusing on those areas as well as the next column. And a non-pneumonia case where the lungs look normal, it's not focusing or not using that as an analysis. And that, again, confirms that the algorithm is working properly. But like you said, the algorithm is probably doesn't have enough cases, so it's not perfect. And here's an example where a COVID-19 case was misclassified as community-acquired pneumonia. So those circles depict those little opacities in this patient. And as a radiologist, I wouldn't say this is a typical COVID-19 case either. It doesn't have those peripheral ground glass opacities I showed at the beginning. So I could see why the algorithm didn't say that was COVID-19. And here's another case where a community-acquired pneumonia case was misclassified as COVID-19. And those round circles depict the densities or opacities in the lung. And it's not bilateral, which you would typically see in COVID-19. So that's why there might be, well, actually, it was misclassified as COVID-19, but typically you would see peripheral ground glass opacities. And if you look at other studies, they've also analyzed lab work, clinical symptoms, and this was a predictive analysis study that used patients' data, lab work to assess what the outcomes of these COVID-19 patients. And they were trying to develop an AI tool that would help predict what patients were going to have more severe illness on initial presentation. And it had some very interesting findings. Once again, the number of patients was probably not high enough, but the predictive analytics is a form of AI that learns from historical data to help predict future outcomes. And what they were able to show, so like I said, only 53 patients, but there were lab markers and clinical signs. This is what was the most predictive of patients to have severe outcomes, or ARDS, which is severe lung disease, acute respiratory distress syndrome. So ALT is a non-specific liver enzyme, and it gets elevated in inflammation or traumas or it's really a non-specific marker. But this was actually the most likely lab marker or sign of what patients would have more severe disease. Myalgias are just muscle pain. So a clinical symptom that you probably wouldn't suggest would be your major thing to focus on when the patient presents, as well as hemoglobin. What areas you probably would have thought would be high on the list would be like white blood cell counts, maybe age, and even imaging findings. So this last box here, key characteristics predictive of diagnosis, including fever, lymphopenia, chest imaging, were not as predictive of severity. So here we can have an example where AI can help us focus on other markers that we might not be aware of as predictive of what patients will have more severe disease. And as we go past AI, we'll briefly discuss neuroimaging, since the patients with more severe COVID-19 disease have shown to have neurosymptoms. And we're in the very early stages of really understanding what kind of neural involvement there is, what percentage of patients are involved, and why are they having these symptoms. So what we know from the current COVID-19 comes again from our understanding of MERS and SARS. This was a study that looked at these viruses and also suggested there was involvement of the brain. So when you look at respiratory distress, they saw that the virus actually involved the medullary cardiorespiratory center within the brain, so the brainstem. It somehow found its way to the brainstem, likely from mechanoreceptors and chemoreceptors of the lung, and it spread via synapse-connected route to the brainstem. And some early reports have also suggested that with COVID-19. So they are similar viruses. It wouldn't be surprising. We also know there's a loss of smell with COVID-19 or anosmia, and that's also an extension of the central nervous system. We look at the olfactory nerves, which is the nerve that helps with smell, or the olfactory bulbs on MRI. And from imaging, everything looks normal on imaging, but this is also neural involvement. COVID-19 associated acute hemorrhagic necrotizing encephalopathy. This is a long diagnosis, but that's a very severe and poor prognostic sign when you see it on MRI. And this was one of the first reported cases. This was a flight attendant in Detroit that presented with severe COVID-19 disease and had a neurological decline requiring imaging. So this is an MRI of the brain. These arrows are pointing to abnormal areas within, we call the deep portions of the brain or deep gray matter. And so column G or box G, where the arrows are, those dark arrows represent blood, where the arrows are pointing to. So the dark is blood. And the last box, H, is post-contrast. So there's enhancement within these regions. And what acute hemorrhagic necrotizing encephalopathy is likely, it's actually more commonly known in the pediatric population. And our understanding of it is that it's response to a lot of viruses can cause this inflammatory response within the brain. So in COVID-19, you've probably heard on the news, probably read papers about the cytokine storm or cytokine response. And other viruses in the pediatric population have caused something similar, where there's a huge cytokine release. There's inflammatory responses throughout the body, including the brain. And these are the findings that you would typically see. You would see this hemorrhage, you would see this enhancement in important structures. So this is a typical imaging finding of this. And as we see more and more cases, it'll be interesting to see if this is a common finding. And maybe this is where AI can start playing a role when we see more and more cases of this. In other cases, other studies have showed also neural involvement. I won't spend too much time on this, but this is a New England Journal of Medicine showing high percentage of cases showing enhancement within the brain, perfusion abnormalities, strokes. I'll just point out a few. So box C, where the arrows are pointing to areas of enhancement where the bright signal is. Box B and D are pointing to areas of enhancement within the brain. And box E, where the little star is, where the bright signal is, that's a stroke within the cerebellum. And these are perfusion studies. So basically, they look at blood flow within the brain. And these COVID-19 patients with severe disease have showed perfusion abnormalities within the frontal and temporal lobes. And that's where the arrows are pointing to. So the color depicts how much blood flow there is to the brain. It's less where the arrows are. So these perfusion abnormalities, it's not very clear why it's only in the frontal temporal lobes. It's only a small number of patients, but that is a concerning finding. And so in conclusion, I try to discuss the evolving COVID-19 infection and some of the past pandemics, some of the CT chest findings and how AI can help, and as well as neural involvement within the brain and spine. Thank you.
Thank you, Dr. Bhatia, for that presentation. Appreciate the time you took to put that together, and quite a few questions did come in while you were speaking. I'll address a few of those now, and I'll go ahead and unmute the rest of the panel here for just a moment in case anybody else would like to chime in. I'll first start with you, though, Dr. Bhatia. First real question is, how do you really see AI helping in radiology today? And particularly, as we're here talking about COVID-19, you talked about the ability to monitor large data sets, et cetera. And I know that somebody also wrote a note in here that said we know that AI can easily quantify the disease region in the lung, but how is this quantitative analysis going to help in COVID-19? So why don't we start with that? Why don't you see if you can address that, and I'll go around the horn.
Yeah, definitely. That's a good question. I think, like I was trying to make a point that a lot of our radiology is very subjective, where we'll say mild, moderate, severe. And as we analyze, we have to do a quick, in pandemics, that we're learning quickly is that we have to do a quick assessment of a large amount of data and try to be as objective as we can. That way, when we refer this information to clinicians, they can be, their response can be more consistent. And that's how it can help us in whether we're quantifying the amount of normal lung to abnormal lung, or even going as far as associating that with lab markers. Basically, it's a quick evaluation of a large amount of data to come with more objective data that will help clinicians treat these patients and stratify what patients can be admitted to the ICU or what treatment options work best. So it really can be revolutionary in how we start dealing with possible future waves of this pandemic or future ones as well.
Right. May I ask anybody else on the panel, maybe Dr. Gupta, or would anybody else like to just add a comment there?
Yeah, I think this is Dr. Gupta. Hi, I think that's a really great question. And, going to talking about it being a little subjective, there are some AI products out there right now that will actually count the number of pixels on chest x-rays to be able to determine whether or not a patient's chest x-rays are improving or the disease is progressing when they've been admitted and they're in the ICU, which is helpful for the patient, the physicians taking care of them, to figure out if the patients are ready to be moved from the ICU to a regular floor unit, and if they're actually improving and might even be ready to leave the hospital, or when they might be ready to extubate them and take them off the ventilator, actually. So definitely some AI out there to make things more objective for us as radiologists.
Thanks for that input, Dr. Gupta. Anybody else on the panel have anything to share?
Yeah, this is Dr. Chang. I'm a cardiologist and intensivist. So for me, we kind of learned relatively late in the game that proning and oxygenating without ventilating was fairly efficacious. So perhaps if we look back on the CTs, we can learn a little bit more about what patients actually may not need to be intubated, but were intubated because the oxygenation problem was so severe. But at least in pediatrics, we've learned that proning is sometimes superior even to a mechanical.
Right. Mr. Stanley, Dr. Jamison, any thoughts from either one of you?
No. Okay. I do have a question for Dr. Bhatia later.
Oh, well, sure. Chime in right now. Go ahead, Charles.
Oh, okay, great. So Dr. Bhatia, earlier when you were expressing your concerns about the variation in the genomic patterns from its original, how have the other COVID viruses fared with that? Do you have any background on any of that? The mutation, is this something that's fairly common with this particular virus? So, could you quantify your concern that, Yeah,
that's a good point. So I didn't spend too much time talking about MERS and SARS, the past coronavirus. They were outbreaks. They weren't pandemics. So the number of cases, I don't know the statistics on it, but the number of cases would relate to the number of mutations in the virus. So the more people this virus can infect, the more likelihood it'll have the chance to mutate and then spread with a different strain. And like I said, I'm not a virologist, but this is my understanding just from background information and reading. But it's not seen with, it wasn't seen in MERS and SARS as far as I know, because it didn't spread as rapidly. But I think the genetic epidemiology of it and the variation of it is related more to the amount of patients that's infected and not necessarily the type of virus. So I think viruses like influenza, which have the capability of infecting a lot of people, also have a lot of genetic variability. That's why the vaccine in general it's not 100% proof or effective. But in this case, it is interesting that as we continue studying it, will the strain continue to evolve? That's one of the concerns. And that's why a lot of countries have stopped really the amount of people coming into the country. They've tried to put a block on that just because of the fear that the strain coming in, it could be different and cause another outbreak or a high transmission rate.
Thank you for sharing that, Dr. Bhatia. Charles, did that answer your question more or less?
Yes, thank you. Great.
So I think what we'll do is in interest of time, we'll move along here to our next presenter, which is Dr. Patrick Jameson. I am keeping track of the questions that are coming in from the audience, so we'll get to as many of these as possible. So Dr. Jameson, I'm going to turn it over to you now, and you can take the mic. I'll mute the rest of us here, and you can begin when you are ready.
All right. Well, thank you, Karen, and thank you, Dr. Bhatia. I started my career at the University of Pittsburgh, and believe me, I learned a lot about expert systems and AI when I was there. And what I want to do in the next few minutes is to really kind of shift gears a little bit. I'm not a radiologist or a COVID expert, and really just talk to you a little bit about what is going on with artificial intelligence and machine learning in healthcare, kind of give you some of the big picture, the major paradigms, and a little bit of methods. So the first question I think that's pretty relevant is, why AI at all? Why do we need artificial intelligence in medicine? And there's a really good reason. Healthcare data is exceeding our cognitive capacity. If you look at the growth of healthcare data over time, you would see that it's increasing 60% faster than data being generated from other industries. And you know, we are just drowning in data. So we need methods that are going to help direct our attention to make better decisions, because this data by itself doesn't really lead to better diagnosis or treatment. So what I'd like to do is just take a few practical use cases, and these stand for a lot of different use cases, and clearly all of them could apply to COVID as well. I'd like to look at screening, assisted decision-making, and risk stratification. So let's just take a practical example here. Screening. So we have a problem that, for example, diagnosing congenital cataracts. It's a rare disease, but it causes irreversible vision loss. So if we could diagnose it in a timely manner, we could intervene to prevent blindness. So how do we do this today? Well, generally, we have specialized centers of care. And in wealthy countries, these are concentrated in academic medical centers. They're expensive, but more or less everyone has access to these specialists, more or less. But in countries like China, especially in rural areas and poorer areas, there aren't these specialists available. So they wanted to build a solution, automate screening, so that they could effectively make these diagnoses in non-specialized hospitals and evaluate them for care and treatment. So how did they go about this? Well, they basically broke down 3 different kinds of convolutional neural networks that are used in analyzing imaging. They developed the first set of network, an identification network. the job of that network was to screen normal people from people that had a congenital cataract. Then they had an evaluation network. This did more detailed analysis to find the area of the abnormalities, the density, and location. And finally, they had a strategist network that would indicate whether the patient should be further evaluated and potentially treated. So how do you go about building something like this if you're interested in building a screening AI system? Well, the first step is training. What they did is they used their specialist hospital to collect 410 congenital cataract cases and compare it to 476 normal cases. So this deep convolutional neural network was used in training and classification, and the results were that they had very, very high accuracy, nearly 99%. And they had very good accuracy, actually, of looking at the characterization of these cataracts. So opacity areas, densities, locations, and treatment suggestions. But we all know that training data is never enough to effectively deploy a AI system. So the next step in the process is you would want to test the hypothesis of whether your data could be generalized to multi-hospitals or many different settings of care. So that's what they did. They looked at 3 collaborating hospitals that were non-specialized to validate their phase 1 trial. And they enrolled 57 patients. As you could see, their neural network agent still had very good accuracy compared to an expert panel decision, including being very good at determining opacity areas, densities, locations, and making pretty good treatment decisions. But I would hope that you would notice from looking at this that maybe the flaw, if you want to call it a flaw, is that they really don't have very many patients enrolled. So this would still give me some amount of pause that you would want to field this system in the way it's been designed. One of the problems you have with screening and where you're looking especially for rare diseases is you're trying to find the needle in the haystack. So if your cases are, let's say, one congenital cataract case for every 100 patients, the prevalence is very, very low. And so in a system like that, even a few false positives are going to cause potential problems. In their case, all 3 cataract cases were detected. They didn't have any false positives. But like COVID-19, if we're screening for antibodies or we're screening for the virus, the more false positives we have, the lower the predictive value of the test. In some cases, that's really not a problem because really follow-up means that we're going to have other specialists evaluate whether this is a true positive or not. So we want to be potentially more sensitive than specific. So the final stage of putting something like this into production is to incorporating it into workflow. And this is really important because effectively, no matter how good your AI system is, if you can't develop a mechanism for which patients are going to get better care, it's all for naught. In this case, how it worked is outlying hospitals would upload their images into a cloud database that then was reviewed on a regular basis by experts at their specialist hospitals. This is a very good method, but the thing is it wasn't really automated. So it makes it more difficult to see it being used routinely because it requires additional effort. So let's switch gears a little bit and talk about assisted decision-making, because this is a big problem, not only in radiology, but in other areas as well. So here the problem is in reporting out tumor mutations. This is extremely difficult, even for experienced board-certified pathologists and geneticists. The reason it's so difficult because each variant, which is a deviation from what a normal gene would express, or a normal base pair of a nucleotide sequence for a gene, if it's affected, it could result in tumor, it could become a tumor driver for cancer. It could be something that is very deleterious to the patient's health. But for geneticists to evaluate these things, they often have to look at as many as 500 dimensions or features for each of these variants. So this is a good example of where the amount of data really is exceeding our cognitive capacity. Their goal was to create a machine learning solution that would effectively focus the attention of pathologists on the most important variants. So here, let's take a look at a typical pathologist workflow. How many cases are they looking at? How many variants do they need to analyze? And as you can see, they have to analyze, in some cases, thousands of variants. Each case may only have maybe 5.5 of significant variants, but they have to analyze these carefully to determine whether they include it in the report or not, in terms of, is this significant in terms of what is needed to go forward with potentially targeted therapy. And you can see only about a quarter of the cases are really reported out as a yes to this analysis. So what did they do in terms of making their job easier? They built a model. They took a retrospective analysis of their routine cancer care patients at MGH in their clinical molecular genetics lab, and they used off-the-shelf tools that are commonly used in building machine learning models that all of you have access to: Python, Pandas, NumPy, Scikit-learn. Then they looked at the area under the curve for a bunch of different machine learning methods, such as naive Bayes, logistic regression, etc. All things that are very easy to do with standard tools. They had to analyze quite a few features, though, for each variant, up to 507 features. And they created two fairly large data sets, one with 20,000 variants, the other with about 16,000 variants. So how do you use this, and how do you make it help with decision making? Well, you have to look at this thing called the receiver operating characteristics, which is basically where do you set the thresholds for either screening a variant or confirming it. Well, if you're screening, what you want to do is you probably want to have very high sensitivity. But having high sensitivity means that you're going to have to accept a lot of false positives. Conversely, if you're trying to confirm, you would like to set a threshold such that you have very few false positives, but your sensitivity is going to be quite a bit lower. And this is true essentially across the board with virtually all kinds of machine learning models. So you're going to make these trade-offs between false positives and between your false positive rate and sensitivity. One way you could look at the overall value of a model is through what is called the Alden Index. It's a statistic that gives kind of a harmonic between your true positives and true negatives. If you have a 0 value, that means your model or your diagnostic test is basically useless. A value of 1 would indicate that there are no false positives or false negatives. This is a perfect test and rarely achieved in the real world. In their case, their Alden Index was 0.93, which is excellent. So how do you deploy this to production? Well, one way you do this is you point out those variants that have a high likelihood of needing to be reported, but that is not the only thing you need to worry about, because one of the things that is very tricky in deploying artificial intelligence systems is that, are they explainable? Will they be accepted by both the physician and the patient? So having explanations of what drove that decision are extremely useful. In this case, they were able to list the top drivers for when the system would classify something yay or nay. And that's very, very important. So let's turn to the last problem I want to discuss, and that is risk stratification. I'm sorry for the misspelling here. This is the state of Maine, and they wanted to really improve lung cancer prevention in the population of their citizens. Now, I think everyone here recognizes that early detection has a much better survival rate than late detection. So what if we could get everybody to have very early detection? Well, one way we could do this is we could do annual low-dose CT screening. But you clearly recognize this is not feasible, not nearly possible in a large population. So we'd like to risk stratify these people to determine who needs more careful examination. And this is where AI can come in, because AI could look at all of the data. So in this case, they built a model using data from the electronic health record that looked at a lot of different major areas like current health conditions, diagnosed diseases, symptoms, and a number of other measures. What the model then did is generated a risk score that described the probability of a diagnosis of new incident lung cancer over the next year. And they stratified those risk scores into low, medium, and high-risk categories. That way you could limit the number of people who would get low-dose CT screening to those high-risk groups. So the steps in the model building. Again, I'm not going to go tremendously into details, but they used very, very large cohorts of patients, over 800,000 patients, with 33,000 features in their original data pool that they quickly narrowed down using XBoost. Then they basically went and looked at this in a prospective cohort using, again, many, many thousands of patients. The bottom line is they achieved area under the curve for their model that was very respectable, 0.881. But you notice here in their data that their various subgroups didn't deviate very much from the overall model. So they couldn't find essentially higher drivers in these subgroups. And then again, this illustrates this trade-off that you're always going to have between false positives as we move to the right on the x-axis versus the sensitivity, which is on the y-axis. And where you set that will determine essentially the numbers of false positives you'll have and the ability to detect cancers. So in this case, they determined these different thresholds, and you could see their high-risk group, they were able to identify nearly 580 true positive patients. But notice their predictive value is on the low side. Oh. So I guess, I'm not sure what happened, but I guess we'll wrap it up there that effectively you can use these models, and I'm not sure what's happening here, you can use these models to really risk stratify patients. And so with that, I'll end off and just say, if you want to learn more, I have a slide at the end that shows how you can get in touch with me or my colleague, Tom Dyer, and also some links to some resources. So I'll be happy to take any questions. Thank you for your patience. Hello?
Dr. Jameson, thank you very much for that. And sorry, I don't know what happened there. One of us, unfortunately, must have accidentally advanced your slides. I did leave it on the final slide there where they can contact you for more information. I'll leave that up for just a moment while we speak a little bit about what you just discussed. I'm going to go ahead and unmute the rest of the panel here as well while we do that. And a question that comes to mind here from me as you were, kind of talking about the data sets and things of that nature, and it really is a question that also comes in from somebody in the audience. They said, do you think a one-size-all sort of model should be used? Or do you think it's better for institutions to train on their own patients due to bias, class imbalance, et cetera? I know that Dr. Gupta sat on a panel with us back at RSNA, and we talked about diversity in data. And as you looked at that last model in Maine, where there wasn't that much statistical difference between the groups, it begs the question, is it a one-size-fits-all approach, or what are your thoughts, Patrick? And then I'll open it up to others on the panel.
Yeah, I think this is a very timely and also very subtle problem that we're wrestling with in the whole field of AI. It's essentially how representative of the data is essentially the application of that data to the groups that we would like to be doing prediction in. Because certainly the more it deviates from really the people that you're going to be applying the model to, the more noise you're going to get. Effectively, the predictive value of the model is not going to be a true measure of the true prediction in that population. So it does require constantly tuning to the population under study. And it can be difficult to tune that model because essentially it really depends a lot on how many cases you're trying to detect, especially if you're trying to detect rare events. It could be very difficult to get enough cases to make your predictions accurate. So, yeah, it's a very much a known problem, and it's not something that's easy to solve.
Right, because you had mentioned the difference between screening and confirming, where you might have high false positives versus low false positives, and we certainly have lots of cases of coronavirus to analyze, and I think that's really where truly the value, hopefully, that AI can come in and play. Let me open it up to anybody else on the panel, just along that topic alone, or maybe just a question for Dr. Jameson that you may have. I'll start with you, maybe Dr. Gupta. Any thoughts?
Yeah, I think, diversity of data is pretty important, and that, we did that panel discussion before, kind of talking about ensuring that we have data from different parts of the world. And I think one of the nice things in this situation is there has been a lot of global collaboration with sharing radiology images so that we can get data from different parts of the world and make sure that it is more diverse. And so it includes patients who have access to regular healthcare screening and also those who don't.
Thanks, Dr. Gupta. Dr. Bhatia, any thoughts or comments?
Yeah, all great points and a good question. And it comes back to the data set. I think the more diverse it is, the better. Because past studies have shown some of the negatives with training on a similar data set. So with an example like CT imaging, where you think every institution is similar, well, every institution is actually has enough variation in it that if you test that algorithm on a different patient population or a different imaging data set, it actually causes some issues. So the artifacts on one scanner might not be in the first trained data set, so that causes issues with the algorithm. So the more diverse your initial data set, the better your algorithm is to apply to different institutions and across the world, really. So I think the end goal is to have a diverse data set.
Any other comments, Mr. Stanley, Dr. Chang?
Well, I actually addressed that question a little bit in my presentation, and I agree with my colleagues that, you know, the rub is in a situation like this, we're trying to deploy these things as quickly as we can so that they can do as much good as they can, but it's always a dual-edged sword. Less data means more chances for noise and variability, whereas it's, as you just said a moment ago, if you wait too long, what is 1 percentage point with, you know, 2 million cases? And so it's, you know, I don't know that there's necessarily a right or a wrong answer. There's just, you know, it's a known thing, though. Less data will lead to more noise.
Mm. We had a
just want to add
that came in. Oh, go ahead, Dr. Chang. You're going to add something?
Yeah, I was just going to add that you know, having a lot of data is often a challenging obstacle in healthcare, and as much as we like to have a lot of data, sometimes that's just not going to be, you know, possible. And people have talked about using something like GANs to generate more synthetic data. The problem, even though that gets you more data, the problem is that if you're not careful with your population that you're generating more synthetic data from, you'll still basically perpetuate the bias. So you have to be very, very careful with the heterogeneity of the data before you actually synthesize more data for your algorithm. The other thing I just want to mention is, I think I alluded to earlier, but it's very, very easy to have a high performance when the incidence of disease is low. And sometimes clinicians and non-clinicians, you know, just don't remember that. So I think as in the case of cancer, it's not hard to have a AUC of 0.859 just because the incidence of disease in the general population is relatively low. And so we just have to remember the limitations of using, you know, that kind of a curve, and probably you want to complement that with a precision recall curve, which is a little bit more honest, I think, when it comes to low incidence disease states.
Thank you for that input. I'm going to take a question here from the audience, and then we'll move on to the next talk, which is Mr. Stanley. This question I'll just throw out to the panel. Recent reports on COVID-19 have indicated that the virus can cause stroke. Can AI differentiate if stroke is being caused by COVID-19? And I know that you had referenced in your talk, Dr. Bhatia, I think some neurological images there where, I think it was yours, where you were showing the MR, how the MR scans were showing things. But for this particular question, do you think AI can play a role in helping differentiate stroke? Who would like to maybe attack that one first?
Yeah, I mean, I can go. I did have some imaging on stroke, and we're still in the early stages of understanding what patients are at risk for stroke. Is there other comorbidities that predispose you? So I definitely think AI can help us in this case, because when you're analyzing, once again, it goes back to large number of cases with no underlying etiology of the stroke. A lot of these, so there are some factors that we do know about. I guess there's a prothrombotic component to COVID-19, which predisposes you to stroke. So if you have thrombosis of arteries, there's increased risk of stroke. So that's one finding that has been suggested in the literature, and I think that's a very likely cause. But what lab markers would be suggestive of this. So there's D-dimers and other lab tests that they're looking at, but it's not really clear right now. So you can have arterial strokes and venous strokes. There's something else to mention. And there was a webinar just a few days ago from New York where they suggested that almost all the patients are having arterial causes of stroke and not venous causes. So that would be something interesting to look at. If there's a prothrombotic factor, how come the veins draining the brain are not thrombosing and causing venous infarcts, and it's mostly arterial? So yeah, AI in this case, if you looked at just all those strokes and compared them to other patients that are similar, they're not having strokes, what would stick out? Right now it's not clear, but AI would help us.
Anybody else want to chime in there on that?
I just want to add that.
Why don't we go ahead and, in the interest of time, turn it over to Mr. Stanley, who is going to begin his talk on whether or not artificial intelligence can unmask the mysteries of COVID-19. So with that said, Mr. Stanley, I'm going to mute myself and the rest of the panel, and the floor is yours. And I know you have a couple of polls there, Charles, as well.
Yep, I was going to mention those. So I'd like to thank the organizers again for the opportunity to speak to this group tonight. And we're about halfway through this thing. And so I just wanted to put everybody on notice that we have a couple of poll questions coming up here. And it looks like we're just shy of 200 attendees. So I think that we should get a robust response to a few of these questions. So with that, we're going to start off with our very first poll question here. Let me see if I can make this happen. So I'm just interested from a demographic standpoint what your role or profession is. And if your bucket isn't on there, just pick the one that's closest to what would match your bucket, be it MD, nurse, imaging tech of any modality, respiratory, lab, support personnel, which would include admin, environmental, so on and so forth, administration, industry, student, or other. And so I'm not exactly sure how this thing works. Do I have to pick as well, Kieran?
No, Charles, you can just advance the slide to share the results.
All right, perfect. All right, excellent. Okay, so, well, I wanted to use this as the opportunity to make a shout out. I seen on the attendee list that my mother has actually joined this call, and she is a longtime retired respiratory therapist. And so I'm using her as a segue into just after you've seen that demographic data, I just wanted to stop and pause for a minute at this particular time and just, read you a quote here from Hippocrates. It says, "Wherever the art of medicine is loved, there is also love for humanity." And so whatever your role is in this whole healthcare thing that we're doing, whether you're front line, middle line, back line, used to be on the line, it's a good opportunity to just stop and say that all of our jobs are essential. They're all important. And on behalf of people even within my own family and my own circle of friends, I thank you very much for what you're doing, and you all deserve to give your own selves a round of applause. All right? So with that, we're going to move on. And so I'm going to shift gears a little bit. I'm not going to talk too granular about any particular methodology or process, but more just kind of a broad view of where we're at. And I'm kind of breaking the way I'm looking at what we're doing with AI. And there's multiples of things besides this, but the things that I'm going to focus on just a little bit tonight are around detection, investigation, and control. Okay, and so the first thing that we're going to talk about is this whole detection and notification screening thing. And let me see if I can advance this slide. So, the first warning that we had of this, the first detection signal that we had was on December the 31st from a company called Blue Dot. They're based in Toronto. And they've been using some AI algorithms to track the spread of infectious diseases, not COVID, but just infectious diseases in general. And so what they found is they picked up this signal on December the 31st that alerted them to a cluster of unknown or unusual pneumonia cases in Wuhan, China. So 9 days later, the WHO confirmed that this was the discovery of the novel coronavirus COVID-19 there in Wuhan. Okay, so that was the first signal. The first public alert outside of China about the disease came also right around December the 30th, and this was from a company, Boston Children, or from a group at Boston Children's Hospital, who had this AI algorithm that they were running called HealthMap. And they were also tracking, they were using online news reports, social medias, and things like that to come up with a heat map of particular signals that they were looking for, and they rated the seriousness of this particular signal as 3 out of 5. But what's interesting about this particular, and I should point out that immediately about this, or I should say about the same time that this was going on, there was also an individual in New York. I think they're affiliated with NYU, and I apologize for not having their name. I think it's Nancy Pollock, but I could be wrong about that. But anyway, they were also identifying signals, and I think they literally at about the same time, they were apart by around 30 minutes or so in terms of reporting this particular incident. And so the reason that health maps is kind of important to me is we all have our own COVID story. And so this is my COVID story. I had just recently returned from Florida at a big meeting that I had been to. And I was looking at all the various maps that were out there to look at. And it just so happened this was one of them that I happened upon at the beginning of this week of March the 10th. I was scheduled to go speak at a conference at the end of that week at Ohio State University. I was to arrive on the 12th, and there was already talk about were they going to cancel, were they going to tone back. There was, if you guys remember, it seems like 5 years ago, but it was, you know, barely over 5 weeks ago when all of this was happening. But this was on the 10th, and what I want to point out, I'm going to try to play this thing, but let's see if I go to the next slide. This is what happened over the course of the next couple of days. I want you to watch these dots start popping up. And it's very hard to see, but in the lower right-hand corner, literally on the 12th is when the first dot started popping up here. And then this is what happened over the course of the next couple of weeks. And so when we talk about rapid dissemination, rapid spread, again, we can separate from news media, we can separate from whatever. This right here is what we know. These are the signals that we're getting. And so there's been a tremendous quick spread across the U.S. But that's how close I came. I came within a couple of days of being in a place. And, you know, I won't reveal too much other than that, other than to say that I was literally walking into what turned out to be a hot spot. There were numerous cases. Those pink dots were representing close vicinity to where I was going to wind up. And so the next question that I have for you before we dive into the next part is, at your particular facility, where if you're, do they use any kind of IT or AI tools for COVID screening? And so that could be anything from a web page that people are locked into to automated temperature checks or whatever it is. Do they deploy IT or AI tools in any way for COVID screening where you're working? And so the answers could be, you know, no, not currently. Employees only get screening. Public only gets screening, or everyone gets screening. So just kind of interesting what's happening as a cross-section. Interesting. All right. So it's kind of hard to practice universal precautions when you, or I guess it's a more the reason to practice universal precautions if there was a great supply of PPE everywhere, because it doesn't look like we have a good, automated, consistent, robust system deployed, at least across who's represented here. So, but there are tools that exist, okay? There are tons of tools that exist for screening, and we're going to talk a little bit more about those in a minute. But the other thing that I really want to spend some time talking about is because this is the area that I live in currently, and that is just the whole validation and analysis of this data that we're getting. What you're seeing in front of you is a representation of the publication of scientific articles and preprints. That's going to be important here in just a minute, related to COVID-19 between January the 2nd and April the 5th. And I would point out that even with these numbers, they excluded quite a number of articles where there was no specific publication date that they could see that would for sure put it within the time window, and there were a couple other reasons that they excluded some. But even with the exclusion of, over 2,000 papers, there was a significant amount of papers that's been generated between January and mid-April. And the reason I say this is important is, several of my colleagues are on the webinar here with me, and for those of you who may not know what a medical science liaison does, I think it's Latin for read a lot of papers, because we spend a lot of time digging through these publications and other publications like them. So if I don't know anything else, I've looked at my fair share of scientific articles. And the point that I want to make is about these preprints, and that is that this is moving so fast, and there's such a sense of urgency that one of the things that makes me a little uneasy is that, and this kind of alludes to the conversation we were just having about data sets, is how much vetting is really getting done of some of this stuff. How much vetting are we really doing for these papers? I mean, I can tell you when I look at papers, like this right here, fine, it's the New England Journal of Medicine, but they got the date wrong in the method. They said they read the labels, but I don't see the MSDS sheets attached. And I know I'm making a joke about this particular paper, but the point is it actually does have some underlying lessons to it. And the lesson is it doesn't matter who you are. If you're presenting anecdotal data that isn't backed up by known science or known methodology, it's very, very easy to get off the beaten path. And so maybe this time it was the president, but it could have been someone else. It could have been anybody that was perpetuating information that hasn't been vetted. So even in a time with a sense of urgency, even when we're getting these flood of peer-reviewed papers, we have to remember our basic science of validation and analysis. So this is just a sample of those of you that have spent any time working in clinical research or any kind of bench science. You understand that you have a process by an academic and scientific rigor that you match, and we can't let that go away even in times like this. And we have to remember that there is no value in AI without subject matter expertise. So at the end of the day, it doesn't matter what kind of signal that you're generating, if you don't have the people to put it in context, both on the front end to help you with designing the features that you're actually looking for, and then on the back end to help understand and contextualize the results that you're getting, it's very, very easy to get off the beaten path. And everybody that's on this panel has multiples of war stories that they could tell you over times where we thought we knew we were going in a certain direction, everything looked good, and then we went and tried it at Hospital B or on Workstation C or whatever, and suddenly we were way off the beaten path. And so again, one of the potential points of failure is if you don't keep involvement with your subject matter experts. And so again, even with this sense of urgency, we have to make sure that we're asking the right questions and having the right people in the room to hear the answers. Okay, so moving on from talking about validation and analysis, you were asking me about this screening. What about robotics? This is an area that's kind of fascinating for me because, spending a good part of my life as a technologist, we hear all the time about, is AI going to replace radiologists? What we don't hear as much about is these frontline bedside workers. Are our jobs safe? What's going to happen to us? And I do think that there's certain parts about what we do that robotics is not ready to meet yet, that there is absolutely a place for robotics. And this is a perfect example right here of a robot this one's deployed in a hospital in Seattle. This is one of the very first patients that had come down with COVID here in the U.S. And I think my polls may have got backwards here, and we're just going to move on and go next slide from here. I think this poll may have wound up in here twice. There we go. So anyway, we're just going to go on to this. So another example of robotics. This is a UVD. So this thing actually, there we go. We're having a little bit of craziness with the slides here. I apologize. This is the slide that I was looking for. Okay, so I have no idea why that did that, but anyway, this particular robot here is a robot that actually is able to stay in the room to minimize the amount of interactions and in and out that any of the caregivers have to do. So basically, this has a lot of the similar technologies that you would see in telehealth, cameras, audio, so on and so forth. It also has the ability to plug into any other types of metrics that you're tracking in there, be it IV, be it cardiac, be it whatever. I don't think that this particular model, I was reading closely about it earlier this week, I don't think that it has the ability to do anything other than monitor. But again, this is being deployed right now as we speak. And I think I see where my slides got wrong. I didn't want to jump past this one because this one's amazing. This one is deployed mostly in Italy right now. I don't think it's being used in the U.S., but this particular robot here, if you can see from the little workflow thing, the cleaning staff orders up for this robot. The robot makes its way to the room. It goes into the room, and with UV light, it's able to disinfect and sterilize. It then notifies them that it's done its job, and it leaves, and the room is now ready for inspection by cleaning crews. So all of the disinfection with the UV light is able to be done automated, and it doesn't involve any personal interaction in the room. So again, it's another way to segregate and contain and use robotics in a way that would help speed things along. Now, what we don't see here is, and it's beyond the scope of today, is all of those personal things that we need, those personal interactions between the caregivers and the patients. And so although we can certainly build ways to communicate, and every day these things get more and more accepted, we've all heard our share of stories, particularly with this disease, because of how isolated the patients have to be, that again, I think it's great for robots to help monitor. I think it's great for robots to help clean or distribute or whatever, but this is a good reminder that there's nothing that takes the place of human-to-human interaction. All right? And so anyway, this is another one of the robotics that's being deployed right now. We already talked about this one, so we'll move on. And then kind of just to finish up here, it's bigger than this talk, but I just wanted to make sure that we understood that even beyond what we've talked about today, there are so many places that AI can be deployed. You know, from a molecular perspective, we can look at proteins, we can identify different existing drugs that could be repurposed, so on and so forth. From a clinical perspective, we had Dr. Bhatia talk earlier about medical imaging and particular things with lungs and neuro and so on and so forth. There's a plethora of those packages out there that some of them, again, have been repurposed for this particular disease, and other ones have come online as this disease became known. From a societal perspective, there's all kinds of research modeling that AI is already involved in. One of the things that, as you see, big in red, and that's why I wanted to tie this in at the end, is that propagation of misinformation. AI is helpful with that as well. Believe it or not, as much spam as you see on social media, if it wasn't for AI, it would be worse. It would be absolutely worse. And so this is a great use in a time like this. If we think about what I said earlier, where the sense of urgency is so great that we sometimes feel like we have to do something and we'll figure it out later. Well, that's exactly what we don't need to do. We can't help propagate and replicate and duplicate any type of misinformation because, again, not only does it hurt the patient that we're doing, but it hurts the one that's going to be downstream. And then again, finally, there's, sharing and hosting all kinds of data models, whether it's clinical, molecular, scientific. All of these things can be operationalized by AI to support, a response to this pandemic. And as you've seen tonight, and as we see every day with the data streams that come through our mailboxes, again, there's a number of ways that we're trying to do this. And I appreciate both the people on this call and the people that I interact with every day to, again, try to fight something that's something that we've never seen in our lifetime. But with that, I wanted to kind of end and open it for questions. The main thing for me, my bottom line message is it's moving really fast. We've got some great tools, but no matter how quick we want to take the plane off, we got to check the locks on the door and, wiggle the flaps and make sure that what we're doing is not going to make things worse. So with that, I thank you, and I open the floor for questions.
Thank you very much, Mr. Stanley, for putting that talk together. And I'm going to go ahead and unmute the rest of the panel here, and we'll take a couple questions from the audience. And while we're doing that, I'll start with one here. You spoke about validation and analysis with regards to how quickly these publications and applications are being released. Do you have any other concerns with rapid deployment of these algorithms and technologies?
Yeah, I do. I mean, I think, that was kind of a little bit of that discussion that we were having a moment ago. There's a term that's used often in the IT and the AI world about the brittleness of a particular algorithm or software package. And basically, what that has to do is that, as we build these things and we deploy them in our lab or on our small cohorts, they seem to work fine and everything's great. And then when we start deploying in areas where there's variability that we don't even understand. Remember, we were talking just a moment ago when Dr. Bhatia was talking about, who would have looked for liver enzymes in these patients? Why are there livers? See, these are the types of signals that we never looked for. Well, that works the other way as well. The AI may be providing us, or we may be providing signals to the AI that we don't even understand what they're doing with them. And so again, when you take it and put it in a different environment, we have to make sure that we validate. When these things are built, if they're built correctly, there's all kinds of validation processes that they go through. And so again, when they're deployed in the field, we just have to make sure that these things don't break on us, because the only thing worse than not having the tool is thinking you have a tool that you do not have.
Right. No, I hear you loud and clear there. We've got a couple of questions from the audience here I think we should address, and one of them jumps out, is there any evidence that AI tools, I think this is the elephant in the room here really, is there any evidence that AI tools mentioned, including the one in the radiology article that Dr. Bhatia, I think, may have had in his presentation, is there evidence of these being clinically used to guide decision-making? And then what is the role of AI evaluation for checks to X-rays in that decision-making process? So, I don't know, maybe I'll let somebody on the panel, Dr. Bhatia or Dr. Gupta, I don't know if you want to take that first.
Yeah. So actually 2 days ago, the National Health Service in the UK partnered with an AI product to quantify the progression or the improvement of patients with COVID-19 in the evaluation of chest X-rays. So I think that there are some places in the world that are using AI right now clinically.
Yeah, thank you for that, Dr. Gupta. I can tell you that I actually interviewed a physician from Chengdu, China at West China Hospital, and they had developed an AI program actually in-house, more or less, to help them primarily for their chest X-rays, but also for their CTs. So they were using that as well. Dr. Bhatia, were you going to comment there? I couldn't recall if that was you or somebody else chiming in.
Oh, no, well, I think that's a good point that Dr. Gupta made. I wasn't aware of that use of AI. I think in general, probably even relevant to COVID-19, in general, most of the institutions I talk to that are trying to study AI, it's more on the research, in the research setting. So it's not been applied to many clinical situations and clinical practice yet. There are a few practices I know for like brain CT screening for hemorrhage or screening for strokes on MRI possibly. But in COVID-19, I haven't seen anything personally from what I've read used in the clinical environment. It's really at the early stages right now.
Dr. Chang, anything you want to add there?
Yeah, I guess maybe being the only non-radiology focused person on this panel, a couple of things. One is, I think what I'm hearing is machine learning for triaging non-COVID patients through the medical system, because we're so focused on the COVID patients that there's collateral damage if we just simply shut down everything and delay treatment for the non-COVID patients. So I just talked to a cardiac anesthesiologist who works with a database in Canada, and what they're doing is using machine learning to figure out how to prioritize the non-emergent but still relatively urgent cases of patients without COVID. So that's one aspect. And the other thing is more logistically using machine learning to figure out how do you recover the workforce in the medical system in terms of number of rooms that you would open up in the operating room, or number of clinics, and who to go into those clinics, and how do you prioritize, how do you exclude caretakers that are higher risk. I mean, all of that is very, very difficult for even a seasoned manager. So using machine learning to help as a partner in making those decisions, I think is going to be very, very useful. And people aren't used to that mindset yet. So I sort of said at another webinar this morning that it took a pandemic for everyone to be more innovative and more adventurous in taking on projects. Telehealth programs are being set up in sometimes less than 48 hours when it took years to get to a decision point. So it's good to see there's some good dividends coming out of this pandemic.
You make a very good point there, Dr. Chang, with regards to, the post-COVID, quote unquote, environment and that surge that, we may see back in imaging centers and really through the healthcare system. And people are staying away from healthcare systems today, whether they're sick or not, unless they're, deathly sick. But people will return to those elective surgeries and things of that nature, and all of these systems will have to adjust and, like you said, figure out how to best utilize their, their system and their resources to manage that. So I'm sure it sounds like to you that AI and machine learning can really help with that. Why don't we transition? Go ahead, Dr. Chang, jump in.
Not to add another layer of complexity on top of this, but what if we got a second and a third wave before the end of the year? How are you going to do this stop and go with patients waiting to get procedures or imaging done, right? So you're going to have a very sophisticated tool to be able to guide you, because humans alone are not going to be enough to make these decisions.
Fair enough. Well, we'll use this as a transition over to Dr. Gupta, who I'm going to ask to begin her talk here in a moment, and then we'll get back to some of these other questions. Dr. Gupta is going to speak about radiology and AI in the fight against COVID-19. So with that, Dr. Gupta, I'm going to turn it over to you. I will mute the rest of us on the panel here, and you may begin when you are ready.
Great. Thank you so much, Karen. Thank you to everyone who's tuning in tonight so we could discuss artificial intelligence in the fight against COVID-19. So I am based over in Boston, and these are my disclosures. I am the medical director of Cure.ai North America, and then I consult with several AI companies, but I'm not going to be giving any medical advice or discussing anything related to my consulting. So I want to talk a little bit about radiology in the fight against COVID-19. I think Dr. Bhatia did a great job starting us off with chest imaging, and then the role of artificial intelligence and kind of combining the two to see what we can do to fight COVID. So let's just start off broadly about diagnosis. So I think one of the things that's gotten the most attention in the media has been talking about testing. And that's been a huge topic of discussion at White House press briefings and in around hospitals, throughout the United States, just making sure that we have accurate testing and we have enough testing for our patients. But what does that really mean practically? So PCR testing is what's referred to when this was brought up in the media. And PCR testing detects viral DNA from a nasopharyngeal swab. So essentially, you have a pretty long Q-tip that is inserted into the nasopharynx. And, there is no perfect test, so it has to be acknowledged that there is a false positive rate as high as 20 to 30%. And, there are patients that get triaged incorrectly with a PCR test at times. And then, at the very beginning, we were hearing a lot about the chest CTs that were happening in Wuhan, and, papers were published about the correlation of chest CTs and combining the PCR testing. And, that's really great because chest CT actually had a higher sensitivity for the diagnosis of COVID-19 as compared to the PCR test in one of the studies that came out of China. And, theoretically, that sounded very exciting at the beginning, and I think there were discussions going on in radiology departments across the country about, what the role of radiology might actually be in the diagnosis of COVID-19. However, a lot of practical considerations came up when these discussions started, and a lot of our professional societies brought up issues with using chest CT as a screening method. And, chest CT is costly and it's not portable. So if you have a patient that's on a ventilator, you're going to have to take the patient to the CT scanner. And when you do that, you're putting the patient at risk because you're transporting them, and you're also having someone travel through, potentially a hallway and an elevator. And, as we now know, COVID-19 requires droplet precautions. So there's a lot of potential risks with the exposure and the transportation of the patient. However, chest x-rays are cheap, they're fast, and they're portable. So instead of taking the patient to the CT scanner, you can actually just bring the chest x-ray to the patient, and you can do it in the ICU or in the patient's hospital room where they're, easy to get the images there, and it's very fast, and the radiation exposure is a lot lower. So I think there's been a renewed focus on chest x-rays, and AI companies have been actually looking at both. So there have been some headlines, recently in radiology business in the last few weeks about artificial intelligence being used to diagnose and assist radiologists with coronavirus in comparison to, community-acquired pneumonia, meaning pneumonia caused by something besides COVID. And, there's been some good success with that. It's helped radiologists and ER physicians quickly distinguish patients who might have COVID from those who might not, who might have pneumonia from another cause. And there was a paper published in Radiology about artificial intelligence distinguishing COVID-19 from community-acquired pneumonia on chest CTs. So, we've got some really great data and some great uses. A lot of information has been gathered with these chest x-ray and CT chest data sets, and combining that with AI. So, what can we do with AI then, practically speaking? So, it sounds really great to think about using AI as a Band-Aid for COVID, but we really have to think about it, practically. How can we have good use cases that make sense, that really help physicians and help our patients and help, respiratory therapists and our first responders? So one use case that is being deployed in some countries right now is triage. So there are AI solutions that will tell you after a chest x-ray is obtained if a patient is at high risk of COVID-19, medium risk for COVID-19, or low risk. And that kind of risk assessment can be really helpful for resource allocation. So when we talk about tests, if we take it for granted, we're talking, we have access to testing, we have nasopharyngeal swabs, we have everything we need to do enough testing. Well, in some parts of the world, that's not always the case. And so if you're trying to allocate resources responsibly, you can combine the chest x-ray, which is easy to obtain, and then decide which of your patients might need the PCR test for confirmation. So if you have someone for medium or high risk based on a chest x-ray, you can then decide to give them a PCR test. Or if you don't have access to PCR testing, you could immediately isolate them from the rest of your patients that are low risk so that they don't spread it, because we know it's very easy to spread COVID-19 from one person to another. And then another consideration is actually volume. So, a lot of patients get chest x-rays when they come to the hospital. Chest x-rays are actually the most common radiologic test that's obtained in patients around the world. And, not only are patients getting chest x-rays when they arrive at the hospital, but once they're in the hospital, some of our patients are getting 2 to 3 chest x-rays per day. So there's a huge volume of chest x-rays that our radiologists are having to deal with. And so that's really where AI can shine, because if AI can separate the abnormals and the normals for us, and there is a proven use case for that as well, then radiologists can detect their attention to the cases that are abnormal, and then they can do their risk assessment and figure out which patients, again, might need isolation. And then AI can also be used for contact tracing. You can use it to decide which patients in a geographic region may have had contact with other potential patients, and getting data from hotspots potentially in one geographic area can be very, very helpful. And why does this matter? Talking about the number of radiologists. So in some parts of the world, there's actually 1 radiologist to 1 million patients, and that's really the ratio that we're talking about. In Tanzania, for example, there are 58 radiologists for 56 million patients. And we're talking about a global pandemic. So what's happening on the other side of the world, yes, it might sound far away, but it's really impacting everyone. And this is not just a local or a community problem anymore. So it is really important for us to think about how resources are being allocated, because this is a fight that we are all in together. And so considerations with COVID-19, going back to screening and triage assessment, thinking globally, in some parts of the world, CT scanners are not available, and maybe a chest x-ray is really their easiest test that they can obtain, and maybe they don't also have PCR tests. So, the chest x-ray really becomes what they're using as their tool to take care of patients. And there are AI solutions out there that cost less than $1 that can be used for chest x-rays that are very helpful in some other deployments that have been used in parts of the world. And there are 2 sites right now. Italy in particular is using an AI solution that I brought up earlier that can tell you if the disease is getting better or worse on chest x-rays that are being obtained 2 or 3 times a day in the same patient, because they count the number of pixels. And, as a radiologist, I'm not counting pixels, but if we have an AI solution that can do that, that is really great objective data that we can give for physicians so that they can take care of patients and figure out if they're getting better or worse, or maybe if they're getting to a point where they might be able to take them off of a ventilator. And then, in some parts of the world, like Tanzania, there's not a lot of radiologists for the number of patients, but AI is, technology that can be used to take charge of a lot of number of x-rays, a large volume of x-rays quickly and efficiently, and to help, the small number of radiologists that they have. It can be really used as an assistive technology to direct our attention to the abnormal chest x-rays and away from the normal chest x-rays. So, there is a lot of AI hype, and I work at an academic medical center, so I teach residents and fellows, and, I get messages from medical students asking if they should still go into radiology, because there are so many headlines out there about how AI can outperform physicians and how, you really don't need radiologists anymore. And, these headlines are out there in the New York Times, Wall Street Journal, all the time. But, for those of you in this audience and anyone who's really interested, I really tell all of my trainees, I really encourage them to click on the article, read through the article, and find the original research study that is being referenced. Because sometimes you'll see that the headlines are really sensationalized, and the research study that they're referring to might have been really small and maybe didn't have a lot of data, but it just sounds really good in a headline in a newspaper. And so, I really encourage everyone to kind of go behind the headlines and do a little bit of research on your own and, kind of read through what the solution is that's actually being proposed and whether there's a practical implication that will help us take care of our patients, or if it's not really as good as it sounds and it's too good to be true. So, I bring up factors to consider with AI. For those of you who are in a position to potentially work with an AI company with a radiology department or for in a hospital system, I bring up workflow integration and ease of deployment. I think these are 2 really important factors that have to be taken into consideration when anyone is thinking about using AI or partnering with an AI company. So there are AI solutions out there that can take up to 6 months to implement because there's a lot of work that needs to be done on the back end, a lot of IT that needs to be implemented, and a lot of upgrades that have to be done across the system. So in 6 months, we don't really know what this pandemic is going to look like. But on the flip side, there's also solutions that can be integrated in 24 hours, 48 hours, 1 week, with a team of on-site radiologists and IT support and data scientists. And so considering the ease of deployment is a really important factor if you're thinking about partnering with AI and potentially for COVID-19 in particular. And then, it's been talked about, we can't just think that just because something has the label of artificial intelligence on it, that it's good and perfect and, good, should be used. And I think that goes back to why local regulatory approval is so important. So in Europe, CE marks, in the United States, FDA approval, all of those mean that this has to have research that's proven. There need to be publications. It needs to be peer-reviewed data. The data set needs to be large, and there needs to be diversity in the data set. Just because there's a pandemic going on doesn't mean that we're going to be lowering our standards for evidence-based medicine, and we need to make sure that whatever solution we're trying to implement is going to be good for our patients. And then finally, we need to consider whether or not the artificial intelligence is something we need or if it's just something we want because it sounds good. And, I think that's something that's really important when you're talking about global health because in low and middle income countries, if they don't have easy access to PCR testing or maybe they're rationing their PCR testing, they might have a real need for artificial intelligence that can give them, a risk assessment on a chest x-ray that's cheap and easy to obtain. Versus in the United States or in Europe or, other high-resource, high-income countries where we do have nasopharyngeal swab access and we are able to do PCR testing or maybe even antibody testing, which is also expensive. In that setting, I'm not sure that there is a good use case for using artificial intelligence. So it really depends on the local clinical environment and what resources and access the healthcare providers have in that region of the world. And then, talking outside of radiology, there are great applications for artificial intelligence that are already being used. There are chatbots that are being used to do risk assessments by asking patients questions about their travel history, sick contacts, if they have fever, symptoms of COVID. Instead of having a healthcare worker go through a questionnaire on paper, you can actually have a chatbot that just goes through everything that is easy for patients, or they can even do it on the phone through text messaging. You can also use AI for data mining. There's large literature searches that can be performed to get information for potential vaccine and drug approvals. And contact tracing is a thing that's been coming up a lot. There are some startups that are trying to use AI to trace patients who have had COVID, where they've been, what contacts they've had, which has led to some privacy concerns and some ethical considerations. And I think that's something that we're going to be hearing a lot more about as we move into the next phase of COVID, after the surges are over and we're trying to, prevent another large outbreak. I think that the privacy concerns of contact tracing are going to come more to the forefront, and it's really something that we're going to have to think about. So, I wanted to think about and discuss what we think is coming up with artificial intelligence and COVID-19. So, in January of 2019, there were already a lot of discussions about how the FDA was speeding up artificial intelligence approvals because there were so many potential AI products in the pipeline. And in February of this year, they had a workshop to discuss kind of streamlining these regulatory approvals. And COVID-19 could really be a turning point. I think it is really spurring a lot of innovation and a lot of collaboration around the world. And, there are companies and people that are working together, with the WHO, with the Gates Foundation, to try to work together to find solutions for drug treatments, potential vaccines, for artificial intelligence. And I think that it could really be a great turning point to see, good products that are able to be used in different parts of the world that do get regulatory approval. And I think because of all the collaboration, we will be able to move faster than we have been in the past, where people were more operating in their own silos. So thank you all for your attention, and I think we'll open it up for some questions.
Thank you so much, Dr. Gupta, for taking us through your slides there and really, opening our eyes a little bit to how you're looking at AI as well. You mentioned, the benefit of it for triaging, potentially contact tracking, and that we're hearing other things in the news about Google and Apple coming together and doing contact tracing, et cetera. But as it really refers back to the chest X-rays and AI, which you said that there are platforms out there, and really that may be the most important thing that we can do to determine who has and who doesn't have, and then maybe using that for triaging. Somebody writes here, given that early detection is important for all respiratory pathology and the extremely high rate of artificial intelligence differential, I'm confused here what they're writing, high rate of AI for accuracy, will it follow that we may see a return to routine chest X-ray screening for the general population? I guess that's the question.
Yeah, I do think that's going to happen. It may not happen in the United States because we do have access to PCR testing relatively easily. But, in other parts of the world where that's not possible, I do think that chest X-rays will play a huge role.
Right. Dr. Bhatia, any thoughts there?
Yeah, chest X-ray, there's a consensus statement from like the Fleischer Society that I showed earlier, and they suggested that it's not needed to be performed every day in patients unless it's going to change management. But every society and every institution is going to apply it slightly differently. So it depends on the facilities you have, how much personnel do you have, and the availability for people to perform the chest X-ray. Do you have enough techs? So like early on in the pandemic, one of the challenges was a lot of the technicians were potentially infected with COVID-19 and had to spend 2 weeks out of the hospital at home, quarantined, and that resulted in a shortage of technicians. So I think every institution has to play it out, and like places in New York where there's a tremendous number of cases, are you able to perform chest X-ray on every patient? That would be a little more challenging. At UPMC, we don't have as many cases, so it's probably more doable. But in my opinion, imaging should be only performed if it's going to change management of the patient. So I think in general, in our NICU or PICU and Children's Hospital, we do perform chest X-rays in every patient on that morning. So it's pretty standard, I think, in medical practice, but from a radiological perspective, it's probably not needed on every patient every day.
Right. Anybody else care to chime in there? Dr. Jamison?
Yeah, I have one comment. In all of these discussions, AI is complementary. It doesn't replace the physician's judgment because none of these systems really can explain at the level of detail the thinking of the human mind. So they extend our ability to diagnose and screen patients, but really at the end of the day, we need human judgment, and we can't really rely on them uncritically. So that's kind of my big picture perspective of all these systems.
Dr. Chang, anything to add?
Yeah, just to echo Sonia's point about sort of looking at your problems that are particularly magnified and numerous now because of what's happened, because of the disruption in workflow and manpower and logistics, that you think about using AI not just for the obvious things, but for the not so obvious things. And I think it's a wonderful, wonderful landscape for just thinking about problem solving with new set of tools and using AI and innovation. I also cover innovation for our hospital. And it is absolutely amazing how many people are all of a sudden just much more innovative than most people thought. And so innovation and intelligence are actually wonderfully intertwined, and I think we're going to see that more and more. And as I said, it took a pandemic, but it kind of brought out a lot of the best features of people that needed to solve problems, basically.
Right. Yeah, somebody writes here, there are questions, do we know the percentage of PCR positive patients who have positive chest X-rays? I don't know that we know the answer to that question, but I'm wondering if that's a potential area where, data could help.
Yeah. Well, I guess, yes. As far as that assessment of using AI in chest X-ray positive and RT-PCR positive patients, that would definitely be an area of interest. I think also asymptomatic patients, where I showed a large number of the patients had abnormal chest findings. So how do you follow up those, and do they become symptomatic, or is this like a pre-symptomatic phase, or is it truly asymptomatic? That's something AI could also help with, and also determine what, actually early on in the pandemic when there was a shortage of lab tests, I think AI would have been helpful in determining what patients actually could have received RT-PCR lab work. It wasn't really clear who should get it, and there was a big controversy of like NBA players getting it early on versus people on the front line. So there's definitely uses of it, and I think, like Dr. Chang mentioned, it took the pandemic to really push us to start thinking about how to use AI in the future environment that we're living with.
Right. Dr. Gupta, there was a couple questions here that related to the use of ultrasound. One person mentions an article on using ultrasound to diagnose and follow children. Was going to ask you to comment on that. And I know that there was another one. I'll ask you to go ahead there, and I'll look for the other question.
Yeah, that's something that has been brought up because, we definitely have portable and handheld ultrasounds available now, so that in the ICU you could scan a patient's lungs and you could see, if there are opacities there and if they do have pneumonia. So that's definitely a use that some people have been considering. But I think that practically there are definitely not that many people who have the expertise with ultrasound of the chest to use it widely. So I think that in those earlier discussions of potentially using ultrasound, I think they deferred to switching over to the portable chest X-rays instead, just because there were more people that could look at a chest X-ray and have an idea of what was going on rather than ultrasound, which is a lot more challenging and not typically used, in the chest.
Right. Yeah. Somebody mentions that chest X-ray still can be considered pretty expensive, depending on where you are and what center, what kind of a center it's in, compared to say lung ultrasound, which we're talking about. And
right.
Yeah.
Yeah. I mean,
so,
that is another consideration. I think that if someone has access to a handheld ultrasound that's cheaper, it doesn't require a technologist if the healthcare team taking care of the patient is able to scan the patient directly. So I do think that's another excellent alternative for low and middle income countries that are struggling with the pandemic.
Right. Why don't we, in the interest of time, turn it over to Dr. Chang, let him begin his talk, and then we will come back to the last few questions that are still coming in, and maybe there'll be some more by the time Dr. Chang is done here. So with that, Dr. Chang, I'll go ahead and mute myself, and I'll let you take control when you're ready.
Yes, thank you very much, Karen, and I really appreciate the session. So I'm going to talk about, sort of gave a preamble for this, about how do you use innovation, intelligence, and I'm not talking about intelligence, but wealth, to hopefully eradicate that in the future. I think it's totally doable. We really do have to work together and to make it happen. So I think we're just seeing these surreal landscapes in this near apocalypse present. On the left is a picture Italian doctor sent me. This is now, and she has to walk to the so she's seeing these fully amazing with nothing. And then I live in Southern California, so something you've never seen before for occasional highway construction where you just empty freeway all over. And I want to dedicate my talk to the doctors and nurses and other frontline workers who really, really sacrifice themselves sometimes in life in combating this virus. Very, very moved by the humanity that has risen to the occasion. So this is a dynamic CT of the virus with a very atypical bilateral pneumonia. And also want to dedicate this talk to the hundreds of thousands of patients that had to suffer. It's just very, very difficult to fathom the suffering that they went. So what's the culprit? Well, as Craig Smith, who is a heart surgeon that writes in his update out of Columbia, and a few of you may be writing, he calls SARS-CoV-2 virus nasty little RNA with a bad haircut. And it does kind of look like that. It uses an ACE2 receptor, so as a cardiologist, I'm particularly interested because I wonder what the inhibition would do, and we're looking at the project to look at inhibitor and whether or not patients with equal amount of heart failure on the ACE inhibitor benefit from being on that. So lots of clinical questions. So as we heard in the media, oftentimes COVID-19 correctly bundle with flu or a bad flu. Here's a major difference. And the R naught number, I used to be global health, so I remember that's a fact. But if you do the math for COVID-19, it's hard to believe that the R naught 2 or 2 now. It might be closer or even above. So it's far more contagious than flu if you just look at it. New York, you could say, is so densely populated, and it's sort of an outlier case. But if you just look at, average density places, I think it's not as reasonably. The other problem with incubation time is long. So an asymptomatic person is affected and infect a lot.
Dr. Chang?
Yeah.
We seem to be having a problem with your audio cutting in and out.
Okay. Is it better?
A number of people post that. I don't know if you're using a Bluetooth device or something, but we are having some issues with the audio.
Hey, is it better? Is it better now?
Well, we'll see how it goes. Thank you.
You can hear me. Okay. So as I was saying, the incubation time is very long compared to the flu. So you're not symptomatic, and then incubation time is long. So it's just the perfect storm for a virus. And then the hospitalization rate as well as the case fatality rate, more likely than not, going to be significantly higher. So here's a map of plotting reproduction number, or R naught, against case fatality. So COVID-19, we try to move it down in terms of the reproduction number and the case fatality, but it's probably going to be more infectious than we thought. And if you think about the worst possible virus is going to be depicted by this red dot. Hopefully it'll come up. Come on, red dot. Okay, seems to have frozen. Let's see. There you go. Okay. So it's right here, like measles and smallpox, extremely contagious and extremely deadly. So in a way, the good news is that it's not up here, but the bad news is that at some point in our lifetime, we'll probably see a virus that's going to be in this. So just a few slides as a primer for pandemic. I think containment is sort of like an epidemiological skirmish. It's a little fight. Hopefully you want to avoid an epidemic or a pandemic, and it's depicted by this curve here. It's very few people. We kind of knocked it out early, contained it, and unfortunately, most countries did not do a good job with the containment strategy, which is extremely aggressive case isolation identification. The next stage in terms of strategy mitigation, and this is what I called epidemiological retreat. So you're trying to slow down the spread and to buy time so that you're not overwhelming the health system. So these are the strategies that are involved with that, and we're definitely practicing, for the most part, these. Now, a terminology that the pundits on TV are not using is suppression, because I think it's a very difficult word for especially freedom-loving, very carefree populations in Western Europe as well as here. I term that as an epidemiological war. So you're at war with the virus now. You're trying to stop or even reverse the pandemic by reducing the R0 or the contagiousness to less than 1. So you're trying to stop the transmission as much as possible. And if you look at the list of things that are listed here, the measures that are listed here, we're essentially doing all of these. So it is not mitigation that you might be hearing in the media. I think the more accurate measure is actually suppression. So where do we go from here? If you look at the various countries, China was severely criticized for having a quarantine that was extremely harsh. But if you look at countries like Singapore, Hong Kong, Japan, Taiwan, and South Korea, which had a slow start, I give them all A's for the most part, because they were successful in containing the virus for the most part. If you look at just sheer numbers, countries like Singapore and Taiwan, believe it or not, were much closer to Wuhan, but have had mortalities in the single digits, if you can believe that. So Taiwan has about 25 million people, and Singapore is less than that, but single-digit mortality is just totally amazing. So what are the lessons learned? Lesson number 1, we have to have early mass testing for this disease for a successful containment strategy. And this is where innovation and AI can really be helpful, because you can use RFID, like Taiwan and Singapore both do, and track people and actually know exactly where everyone is. The second lesson is that we really need real-time predictive modeling that's much more sophisticated than the traditional, what they call SIR, epidemiological modeling. So we have the AI capability to do it. We just need to really sort of infuse the latest AI deep learning technology into epidemiology far more than we're doing now. And I think the government, the government agencies admit themselves that they need to have a modernization of data science. And lastly, I think we need to really incorporate tokenization and intelligence to expedite the aspect of care that we need to deliver. So on the left, let's see if this plays, is a, it won't play, but it's a ventilator that was made from about $100 worth of materials. And on the right, thanks to my Georgia Tech colleagues. So in other words, ventilators don't have to be 200 parts and $50,000. This is on the right is AlphaFold, which is from Google. It's a deep learning way of visualizing and predicting protein structure based on the genomic sequence. So this is very helpful to combat the virus. So I think in essence, we want to go from a traditional model of treating pandemics for us to save a lot of lives. We need to totally change the paradigm in the future of how we look at everything from data collection, predictive modeling, to medical therapy and vaccine development. I mean, I shudder every time I hear the experts say that it's going to be 18 months for a vaccine. Why does it have to be 18 months? Just because it's been traditionally 18 months, it doesn't mean going forward we need to adhere to the traditional model and timeline at all. We don't, with the world being so interconnected now, we don't have the luxury of time like we might have decades ago. So in summary, I think going into battle with viruses without a public health strategy like we've seen in some of the Asian countries is like going to battle without armor. We wouldn't want that. And then going into war with viruses without AI and innovation is like going to war without weapons. So I think in both situations, it's just not acceptable. We need to have both smart public health strategies that can use technology and AI, as well as just innovation and AI in general for therapy as well as predictive modeling. So imagine 10 years from now, we're faced with COVID-19. Wouldn't it be nice to have a very proactive approach with tracing strategy and mass screening that you can do at home, coupled with real-time data science-driven modeling so that you literally get your personal instructions as to what you should be doing that day. Can you go to a store? Do you need to wear a mask? Can you go to a movie? All of these things should be much more precise than we have now. And also, we should deploy AI as much as we can on the therapy side as well. So I remember the really wise words of Alan Turing, the progenitor of AI and British mathematician, who said, if we just substitute viruses for the Enigma machine that he was able to decipher, that these are really extremely well-designed machines. Viruses might be very simple in terms of the structure, the molecular structure, but it's actually extremely efficient and has elements of what we call a complex adaptive system, many, many parts that work well together. The problem we have now is that we're only using humans to try to beat it. That's why we're not succeeding. But what if, and he said, what if only a machine can defeat another machine? In other words, why can't we, even the odds of succeeding by deploying machines, and in this context, it will be artificial intelligence and other technology, and pair up. The only thing I would maybe add now is that what about machine and human? Then almost for sure we'll have a differential event. And if that's too nerdy for you, a more poetic quote is from Albert Camus, who wrote The Plague, which is very appropriate, to quote him, in the depth of winter, I finally learned that within me there lay an invincible summer, which hopefully will come. And if we're lucky, perhaps this RNA virus, like some of the other of its cousins, will start to fade away in the summer months. But I totally agree with my global health gurus that it's almost, I think, more than 50% chance, if not 80, 90% chance, we're going to see a second surge and a third, perhaps even before the coronavirus gets a vaccine that's going to be good for therapy. So if you're looking for a read, since a lot of us are locked down, you have maybe a little bit more time than you used to. This is a book by Michael Osterholm, The Deadliest Enemy, one of the best books I've read on global health and pandemics. It's when you read some of the chapters, you're going to be a little bit depressed because he clearly called this a couple of years ago, that this was going to happen and warned against that this was going to happen, and very few people were listening or reading. And then just as prescient was Bill Gates' talk from 2015, he also outlined a strategy that we can still deploy to overcome the pandemic. And so I get asked a lot, where do I think this pandemic is? I'm just going to borrow Winston Churchill's words. Now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. And I think we're in the third mile of this marathon against SARS-CoV-2 or COVID-19. So I think it's really, really important to fight this battle, but at the same time be cautiously optimistic. I just want to show, I'm a pediatric doctor, so I always show a picture of my two girls. And this is Emma and Olivia. They just want to send everyone their love. But Olivia wants to be a doctor to help patients with coronavirus. So for a 5-year-old to tell me that, I was very moved that she's already thinking about how to join this this really, really difficult battle. And let's not leave a legacy where she has to continuously worry about pandemics. Let's eradicate pandemics in general. So thank you very much.
Dr. Chang, thank you again for the time there and putting that together. You said some pretty provocative things there that jumped out at me and a few of our audience members as well. You know, the first thing, and I'll unmute the panel here as we start here, I wanted to ask you was, you know, you talked about predictive modeling and that AI does have the capability today to do that, you know, on a sort of much larger scale. You said that governments would need to get involved. You know, maybe could you just expand a little bit about that? Because I think at the end of the day, it's, you know, it comes down to prevention and, you know, understanding, you know, how do we see this coming, et cetera. Maybe you can just expand on, you know, how would that work, the predictive modeling?
I think, yes. I think one of our speakers alluded to Blue Dot, which is a clever way of using intelligence in the form of natural language processing or picking up words, as well as machine learning to look at everything that's written, published, and transmitted in the social media, as well as passenger travel information on airlines. So they can put it all together and fairly accurately have an early warning system set up. By the way, about a dozen international health organizations use Blue Dot. I'm happy that our governor in California decided to hire Blue Dot. So I think I'd be curious to hear what Sonia has to say. Boston, which is getting a really bad run. But, you know, I think that's made because from the early, if you recall, San Francisco and California were the first among the first places to lock down. I think they had really idea where this was going to be headed based on some of the Blue Dot. And that's the difference between Blue Dot and some of the logical models is that it's real time. It's going to take all the real time and use it to predict for the following day, right? The thing. And you remember on the media, there were predictions of death from 25,000 to 4 million. Well, I don't think you even need modeling to have that big a range when you guess the number of people that are dying. So there has to be something much more sophisticated. And I think the answer comes from using real-time machine and deep learning to be able to predict much more precise based on geographical area, based on population density, how many people are abiding by the mitigation, depression, stress, and actually accurately the following few days where the number of deaths and the number of diagnosed cases. And you can do that around the country. This way you avoid sort of government with these difficult decisions, almost impossible decisions, when to open and then face the consequences if they get wrong. So it just, I think this whole pandemic really magnifies deficiencies in the system, from the public health infrastructure to how we gather data to the social inequities in this country, as well as how far behind we are, deploying AI in public health. Now, AI, as you heard, is really effective in some areas like medical imaging and even some areas of decision support, but it's definitely way behind public health and infectious disease sectors.
Thank you for that, Dr. Chang. I don't know if anybody else wanted to comment before I get to some of the questions that have come in from the audience. Dr. Gupta, or anybody have a comment there? I'll take this next question then. So there's a question here that says, the cycle of infection requires a susceptible host. The U.S. population is riddled with autoimmune diseases and other comorbidities, making us immunocompromised and therefore more susceptible. Lifestyle factors have a massive impact on immune health. Is this being analyzed? Could AI be useful in this area? I think it's a good question. Dr. Bhatia, your thoughts?
Yeah, that's a good point. I think as the research is coming out, there's definitely the comorbidities that predispose patients to COVID-19. And it's not just obtaining or getting COVID-19, it's the severity of the disease. We know there's patients that have mild to moderate to severe disease. It's not really clear why, but maybe an AI analysis can predict. So I think an AI predictive model of what patients will have severe disease and what patients will need specific types of treatments is where really an interesting focus would be with artificial intelligence. But like I said, a lot of these things are really early stages. So I showed a kind of glimpse of what AI was trying to do with some of those lab markers and clinical symptoms. And that's kind of the direction I think is going to be very useful. And that also would play a part in imaging findings and predicting what patients, like I showed an example of, they're required to go to the ICU, or what patient can go home from the emergency department.
Dr. Gupta, any thoughts there?
Yeah,
from what Dr.
absolutely. I think you could use natural language processing to do retrospective chart reviews of patients that have COVID. So you could train your AI to just look for specific keywords. Once you've separated out all the patients that have COVID confirmed, then you could use the natural language processing to look for other keywords in their histories, that might make them higher risk, like these comorbidities, like the words hypertension or hyperlipidemia. And then you could, transition that information into separating out the data sets to potentially make models. But yeah, I think natural language processing would have a great role in something like that.
Yeah, that certainly seems to make sense. Dr. Chang, any thoughts there?
Yeah, I think AI can be very useful to at least start maybe using cluster analysis, so it's unsupervised learning. So you don't make any predictions, let kind of the data cluster and then see what populations are high risk. Or know that there's some social equity. Patients with a higher BMI, for instance, have a higher mortality. So you remember your histology adipose tissue happen to have a much higher density of ACE2 receptors. So maybe it's just easier for viruses to anchor themselves in cells if you have more adipose tissue. So, and the other population that I'm particularly fascinated with is children. Why children are not affected like with influenza or other diseases. So I think we can learn a lot by trying to figure out why children are relatively free from severity of this mortality. So one of the things I was thinking, what's in terms of the immune system between children and adults, is that they're not as severe. Maybe the overreaction to this virus is not as severe. They're also closer to vaccination, right? If you think about childhood vaccinations, maybe one of those vaccines, in particular the polio vaccine, the polio virus as well, maybe that's conferred some degree of protection and enough to neutralize the a bigger viral load. So we're looking at building a couple of projects. I think it's going to be fascinating to figure out why for this particular virus are less affected.
Right. Couple more questions here and we'll wrap things up. I know this has been a long talk today. We're just hitting the top of the hour. Somebody mentions here, you know, is there any work that uses AI to distinguish COVID-19 with other viral pneumonias from CT scans? Anybody know of any other applications there?
Yeah, there are some AI products that can tell COVID-19 apart from like community-acquired pneumonia. So there have been some publications that did have good sensitivity and specificity for that.
Thank you, Sonia.
Yeah,
Dr. Bhatia,
the one
chime in?
Yeah, the one that Dr. Gupta mentioned was the one I showed where they differentiated using software, AI software to differentiate community-acquired pneumonia from non-pneumonia, and that's where those hot zones were. That was a good example of convolutional neural network. And that was the point I was trying to make was when you look at radiologist perspective of COVID-19 chest imaging, it can be very non-specific, and it can overlap with other other pathologies with the lung, such as drug toxicity, other infectious diseases such as influenza. But the more we use AI algorithms, we're starting to see that there are patterns maybe that we didn't pick up on, or other objective markers that we can use. So objective biomarkers can help us differentiate not only severity, but other disease processes such as COVID-19 from influenza. And that's what that one study I think was very useful, even though the numbers were pretty low as far as the number of patients they put into the study. So the patient population was low, but as you build that up with more patients, you can increase the sensitivity, and specificity was already pretty high in that study. So it's definitely promising use of AI in differentiating COVID-19 from other infectious diseases, and even from non-infectious processes within lungs that can overlap with imaging findings.
Thanks for that, Dr. Bhatia. Well, as we've hit the top of the hour here, I think we'll just close with some quick final comments. I'll give you all just a moment to respond. I'll start with Mr. Stanley while the rest of you collect your thoughts. Just some closing comments, Charles, on really the role of AI as we think of COVID today. Maybe it doesn't have all the answers at this moment, but it certainly can play a role as we continue to move forward. So your closing comments, Charles.
All right, great. Well, thank you again for organizing this. I appreciate the presentations by my colleagues here. And one of the things that we didn't touch on tonight, and we certainly don't have time to dive into it now, but I just mention it for your own reading if you chose to do so. But, the ethics around all of this, those of us that have been involved in this field over the past few years, we spend lots of time discussing that if these things ever really break out of our lab and get deployed in a large-scale way, there's a lot of ethical concerns that we haven't worked out yet. Who owns the data? What's the level of transparency? So on and so forth. And so when we start talking about deploying tools at an epidemiological scale, suddenly all of that becomes a real big deal. And so I don't think we've spent enough time on that yet because, again, it's the sense of urgency and the vetting. But it is funny how we argue about Google Glasses for years and they go away, and then suddenly everybody has an Alexa and Siri device. So we take things in fits and starts, and it's going to be interesting to see societally how much we accept some things post-COVID that we would have spent years arguing about before. So I just think that the ethics question has not been solved yet.
Dr. Gupta, any closing thoughts?
Yeah, I think I'm just really hopeful that we will be able to successfully use AI to a great capacity in the fight against COVID. I think that there are some good use cases that have been deployed in different parts of the world. And I'm really optimistic that, it'll be a great tool to help us because, I agree with Dr. Chang. I think there's going to be another wave and another wave. And, it did take a pandemic, but I think that there's great opportunities for global collaboration now. And this is just bringing out the best of us.
Thank you, Dr. Gupta. Dr. Jameson's final thoughts.
Yeah, I think we're in the very early days still of AI in medicine. I know it's been something we've been working and researching for years, but an MIT study showed only 5% of providers use AI in any way. And our challenges are still ahead of us to make these systems accurate, explainable, and integrated into our workflow. So these are areas that we're going to see more and more research in, but I'm very hopeful that it's going to have a big, big impact in medicine. But we're still in the early days.
Thank you for that, Dr. Jameson. I couldn't agree more. Dr. Bhatia, any closing thoughts?
Oh, yes. I'd like to thank the panel and the organizers for this webinar. It's definitely informative in many ways and supports what I believe is that AI will have a huge impact in medicine. And specifically for me, interested in radiology and how to apply AI and other techniques such as radiogenomics. I definitely see a future of this, and I think the biggest challenge is, like been mentioned before, is applying this in the clinical environment is pretty challenging. And I go back to just other techniques in radiology that have been stuck in the research field and haven't been applied clinically. This is another example, but I think as we apply this more and there's so much investment in this, we'll definitely see AI play a larger role, and you're seeing journals dedicated just to AI now. So radiology has their own subjournal focused just on artificial intelligence. So investment like that, and then you have the University of Pittsburgh and UPMC with their own institute dedicated to artificial intelligence. And I'm big into translational research, so I'm also really interested in how to apply this in the clinical setting. And that's kind of the movement we need to make this more useful in the future and to help prevent and treat pandemics like this.
Yeah, very well said there, Dr. Bhatia. I couldn't agree more. It will take a village. Dr. Chang, final thoughts? I'll let you wrap it up.
The final words. Well, I think a couple of things. One is, I think the U.S. has a wonderful medical care system, but we don't have a good healthcare system. And I think, unfortunately, the pandemic really kind of shines a light on all the deficient areas and just basic public health. And I hope, just like we don't spend enough money on battling obesity, we kind of wait until they have a heart attack and then we put stents in. I'm hoping that we don't always focus on the technology and we start investing more seriously on public health measures that will help mitigate this, very, very daunting enemy. So I think coupling innovation with intelligence, I know we can overcome it, and it'll be a continual battle. It'll be a war for a couple of decades, because it's not like the viruses are just sitting there and not get smarter either. I think the viruses are getting smarter. They figure out how to jump from animals to humans. They know how to survive. And I know it's ridiculous to think that viruses have intelligence, but they certainly act cohesively like they have some intelligence. So we have a long road ahead. It's a long marathon, and we're in the third mile, as I said. But I think we have to persevere with some things that viruses don't have, which is passion and compassion. So thank you for the opportunity for this wonderful webinar.
Well, Dr. Chang, thank you very much, and a big thank you to really all of you on the panel, Dr. Gupta, and Dr. Bhatia, Dr. Jameson, Mr. Stanley. All of you did a fantastic job. So thank you on behalf of all of us here at Applied Radiology for taking part tonight. And I'd also, as a reminder, like to thank Adjunct Assistant Professor Kenneth Wheeler for his assistance in making this program a reality. And of course, our esteemed panel, who I've just thanked. So thank you to everybody who also joined us this evening. I hope you got something out of this, and certainly we will look forward to seeing you online again for another Applied Radiology Expert Forum webinar. With that, the program has now ended, and be safe and have a nice evening. Take care.